Hey everybody, it's Karen Anderson here with Aortic Hope. Tonight is a live Q&A. We're fitting it right in at the tail end of February, which is still Heart Health Month. We just celebrated aortic valve or heart valve disease day on the 22nd. So for the first time, we're going to focus tonight's live event with Dr. Stacy Fisher about the heart. We've never really talked about the anatomy of the heart and different things regarding the heart. So I'm kind of excited about tonight. But before we get into that, let me tell everybody, please click like, please click share, click subscribe, click the bell so you're notified every time we go live. Feel free to chat questions or comments. Just know they're going to live out there forever. So be kind. There's also an anonymous form link. If you want to ask questions and you want to stay anonymous, we'll get to those as well. So Dr. Fisher. Stacy Fisher, why don't you tell everybody a little bit about yourself? You will introduce yourself better than I will.
Well, thank you so much. It's an honor to be here. This group is an amazing group of people, of survivors of aortic disease, and it's an honor to be part of your care. And again, please ask anything. So my background is adult heart disease, and I did subspecialty training in adult congenital heart disease, meaning taking care of people that have grown up with structural disease or genetic predispositions to disease. So we do a lot of family screening, a lot of care, a lot of imaging, pre-surgical planning, hoping to make this a better experience and improve expectancy for aortic patients. This is a really fun month for me. I don't know a heart doctor that doesn't like Valentine's Day or Heart Month. So I think it's a wonderful opportunity to share some information and try to improve our health.
Great. I love it. Well, let's get right into it. Let's talk about the anatomy of the heart. We're not going into the aorta unless people have questions about it, of course, later. So let's talk about the heart. I couldn't even tell you what chambers what. I'm lucky sometimes if I remember what the names of the valves are. There you go. There's your heart, everybody. I'm going to let you take this away.
So we're going to go for a diagram.
Okay.
Which I think is very helpful. So most people, the normal heart has 4 chambers, 2 atria, if I can do this backwards, and 2 ventricles. There's a septum between the bottom 2 ventricles and through the top 2 atria that separate the venous and the arterial blood. So you really have 2 separate circulations. You have blood coming out from the veins, oxygen depleted from the tissues, returning to the right atrium of the heart, then to the right ventricle of the heart, out to the lungs where it picks up oxygen, returns back to the left side of the heart through the pulmonary veins, oxygen rich and red, through the mitral valve into the left ventricle. And the left ventricle is generally your high pumping pressure chamber, and that pumps the blood out to the body. This is a higher pressure chamber because the pressure in the aorta out to the body is generally average, say 120/80. If you think about your blood pressure, the pressure to the lungs should be more like 25/10, just as an average number. So it's a very different amount of pressure, and the muscle, because of the pressure it's pumping against, is going to have different size and thicknesses. The left ventricle function normally at rest pumps about 60 to 65% of blood out on each beat, and you may recognize that as an ejection fraction. Mm-hmm. The right side pumps a little bit weaker at rest. Both sides should be able to increase what they're pumping when they need to have reserve. So if you have a fever, if you're running, if you're under stress, happy or sad stress, you're getting married and walking down the aisle and your heart is pumping, you should actually have a higher pumping function. So that, again, 100% is not the normal number. 60 to 65% for the left and a little bit lower for the right is your normal number. The valves are very interesting and have exquisite design. So the mitral valve is a 2-leaflet valve. It can be affected by having extra tissue and in connective tissue problems. Sometimes you have redundant tissue that can go back and be a little bit floppy, and that's called prolapse. Or you can have changes in the way the valve is formed. The tricuspid valve over here is also a 3-leaflet valve. And again, that's meant to be against lower pressure, separating the top and bottom chambers. The outlet valves, your pulmonary and aortic valves, are both naturally 3 leaflets, generally about the same size as one another, and are meant to go against higher pressure and separate the heart from the vessels above the heart so that blood goes forward and doesn't just sink backwards. This is
amazing.
a good depiction of an aortic valve. This would be a normal aortic valve with 3 leaflets. Looks like a Mercedes sign when it's closed. It should be thin, pliable leaflets that just open and close all the way to the wall and give you room to get blood out. So just a little bit about the normal heart anatomy that Karen requested.
So when we talk about the heart, there's a lot of different things, I'm sure, that little conditions and things, but I know people talk about that they've been told they have a heart murmur. What's a heart murmur?
So a heart murmur is really like a car noise. It's
Okay.
a turbulent sound, and some are normal, some are good, some are bad. They have different characteristics, but they should be explained. So if there is a noise, there should be a reason for the noise. And it should be something that's investigated. One of the most common ways to investigate that would be an echocardiogram or ultrasound of the heart, where you can actually look and see the valves, look for turbulence, look at the direction of flow, look at the speed of blood. And through that, you can measure some of the pressures through pressure physics equations, one called the Bernoulli equation, where you turn the velocity into pressure so that you understand more of how the dynamics in the heart, the filling in the heart, how much fluid is somebody retaining fluid, or do they have a murmur because they don't have enough fluid, they're dehydrated or anemic, and then the heart's pumping so hard that it actually has a flow murmur.
Okay. Other things that I've heard people talk about. Just to get back to that real quick. So you would hear a murmur on a stethoscope check, but it wouldn't necessarily tell you where that is coming from. Is that typically from a valve? Is that what you're hearing on a murmur? Is that where it's originating from, or it can really be originating from anywhere?
Well, a heart murmur should be somewhere over the location of the heart,
Okay.
right? So, and it should be a sound that actually you can discriminate if it's during the squeezing or relaxing phase of the heartbeat or if it's pancardiac. Something like a dialysis fistula would have a machinery-like pancardiac murmur. It's continuous. And
Okay.
that's the same sound as anytime you connect an artery and vein, like a patent ductus arteriosus would have that same sound. Or a fistula, a different type of fistula could have that sound. But there are characteristics. It's very similar to trying to pick out a musical instrument in a symphony.
Oh,
So
okay.
the training is really trying to decipher where in the symphony that sound is. Is it in the squeezing or relaxing phase? Does it have to do with one valve or another based on the location and the radiation of the sound? And we also listen to the pitch. Is it higher pitch, low pitch? Does it peak late in the cycle or early in the cycle? Can you get the flute sound? And when is it happening?
That's,
So
and I've never heard you describe that. But well, again, we haven't really talked about this, but I love how you just, the aorta is a candy cane and your heart is a symphony, and you're trying to distinguish what instrument is maybe playing out of tune, what's playing what, and what's standing out. That's really interesting. So when you have an issue with a valve, we have talked a lot about aortic valve, and we know that having a bicuspid aortic valve could be genetic or hereditary. What about, so you said mitral had 2 cusps, correct? Or 2 leaflets?
yeah, the mitral
So
has 2 leaflets.
can any of the other valves be born with something different than when they're supposed to, like the aortic can be?
Oh, absolutely. You can have a bicuspid pulmonary valve. And I have patients with a unicuspid aortic valve, which looks like a C opening and has
Wow.
one leaflet that attaches in the middle and it opens like a flap. You can't have a closed valve.
I would think not.
No, it
That would be a
doesn't work.
problem.
Um,
Right.
but but there are unicuspid valves. Often those are valves that have some of the highest gradients and present younger. The bicuspid valve is the most common. It's as high as 3% of the
Mm,
population. Some
yeah.
estimates 5% of the population. The trileaflet valve is your normal valve. And I do have patients with a quadricuspid aortic valve.
Wow.
Most commonly, there is a COL variant of vascular Ehlers-Danlos,
Hmm.
where people often have a quadricuspid aortic valve.
Okay.
So it does go with some of the genetic issues. Sometimes you
Hmm.
find it in isolation, rare. So
Hmm.
important that there are a lot of variations. And then the bicuspid valves have a lot of variations. So
So I know that,
there are
and you listen to,
classifications.
and you pay attention to the aortic, right? Because sometimes that can form an aneurysm. And so we've heard a lot about how that gets diagnosed and managed and treatment. What happens if it's like a mitral valve or a pulmonary, if it's like deep inside the heart? I'm fascinated by what would happen if they have a bicuspid valve. Um, you're not going to have an aneurysm because it's inside the heart, right? So what would happen, and at what point do you have to do treatment,
So,
and how do you do that
and there
treatment?
are, all of these valves have different roles. I'm just going to shut the door here real
Okay.
quick.
It's that end of day cleaning. Everybody's
Sorry
got to
about
do their
that.
job.
They're really nice too.
Yeah.
All of the valves have different associations and problems that can be associated with them.
Hmm.
For example, the pulmonary valve probably is often more affected by genetic issues than even the aortic valve,
Wow.
and there are pulmonary artery aneurysms that are very significant,
Really?
and certainly are common in the congenital heart community.
Okay.
So each valve has its issues,
Hmm.
um, just like car valves. And then there's also wear and tear, often shows up in the elderly rather than in younger people. So in general, a lot of the structural or connective problems will show up younger, and a lot of the wear and tear problems will show up older. Or people with underlying structural problems may be more sensitive to things like environmental exposures, may not tolerate environmental challenges as well,
Hmm.
and may get earlier wear and tear, or may have infection issues from things like bacterial infections, dental infections, for example,
Hmm.
that actually show up and cause earlier problems. And the mitral valve and aortic valve are probably two of the most prone. In the intravenous drug population, the tricuspid valve is actually the most commonly affected valve, because
Okay.
the bacterial infection is in the veins, and the tricuspid valve is the first valve they see.
So can you replace those? Are there choices for those as well, mechanical versus bioprosthetic?
Yes and no. So the tricuspid valve, I do have some patients with a mechanical valve. We also more often use the bioprosthetic. The
Hmm.
right-sided heart valves have more clotting issues, lower
Okay.
flow than the left-sided. So it's rare that we actually use the mechanical valves. We're starting to discuss it a little more as we have newer low-profile valves that require lower levels of warfarin,
Hmm.
compared to the older style valves, and may be more amenable to doing well in the right side. So it's a moving target. We also have progressive catheter-based interventions for all four valves now.
Okay. What does that
So,
mean?
for example, we have the aortic valve. We have a lot of catheter-based replacements,
Hmm.
transcatheter valve replacements. The pulmonary valve, we actually have been doing that even longer than the aortic valve, with tissue valves that are mounted on stents that can go
Oh,
in through a balloon
okay.
and be expanded into the pulmonary valve to replace a narrow or leaky valve.
Okay.
Um, the tricuspid valve, we are just starting to address with things like clips, although there is not a catheter-based valve replacement that is FDA approved or available or working well.
Hmm.
So we're working on that at this time. The mitral valve, there are certain anatomies where catheter-based valve replacements can be done. And there are clips that can be placed to try to minimize how leaky a valve might be, trying to
Okay.
bring leaky leaflets together, balancing the risk of making it too narrow, but trying to reduce the leak. So many
Okay.
procedures can be done to improve valvular heart disease now through the catheter without open surgery. And that is emerging and improving technology. And it's been a whirlwind of exciting techniques to actually try to avoid open heart surgery for many people, but not
So
everybody. Sometimes
are you going in through wrists or are you going in through the groin?
it depends what somebody needs. The stents often can
Okay.
be done through the wrist. The
Okay.
valves are all done either through the groin, sometimes through the carotid,
Mm-hmm.
sometimes they're done transhepatic. The interventionist may go through the liver, into the
Wow.
vena cava, into the aorta, into the
Okay.
up into the aortic arch, down to the valve, and then when they come out, they have to put a closure device between the vena cava and the aorta so that they don't leave a hole. So
I'm
these
telling
are
you, my mind is blown because we talk so much just about the aorta that, I just take everything else for granted. And what you're telling me is just so much information. I feel like I'm on brain learning overload right now and I'm completely fascinated. Now I want to dissect I didn't want to dissect in high school, but right now I wish I could be dissecting a heart and just looking. I would just love that. That's just me.
so here, for example, is just a little piece of an aorta. The
So
valve.
is it that
The
big?
valve
Are you
that goes
telling me
here.
it's that wide?
Yeah, this is somebody's the size of somebody's aorta.
That's
You can see this
huge.
a little better. These are the coronaries coming out of the aorta. And this person had a surgery during a dissection, and this is the surgical suture
Mm.
line. I don't know if you can see that,
Mm-hmm. Mm-hmm. Oh yeah.
but and a pseudoaneurysm developed at the suture line.
Is that what that is? That's a bulge?
That is, and if you look inside, you
Yeah.
can see, looking inside, that there's a gap here
Mm-hmm.
above the suture line where blood is making a pseudoaneurysm, which is essentially a hole
Wow.
where there's a risk of rupture. So the interventionalist had asked for this model to try to fit catheters in here and get in there and actually close off the pseudoaneurysm that's pouching
That's
off the side. So
amazing.
you can see the sewing ring, you can
Mm-hmm.
see the side. This is a model made from somebody's CT scan. And again, you can see how the coronaries come off. They need to
Yeah.
be above the suture line, and the coronaries are really one of the reasons we haven't been able to do too many catheter-based stents for the aortic dissection or for ascending aortic aneurysm, because you need flow to go into them.
Right. Yeah.
So you
That's
don't want to
amazing.
cover or change the catheter. But the catheter-based interventions are emerging. So when we sometimes ask for extra imaging or
Mm-hmm.
taking a little bit more time, maybe have a multidisciplinary group of your cardiologist or vascular doctor, the interventional doctors, the
Mm-hmm.
surgeons. We actually put groups together where we will discuss specific anatomy cases. If somebody has maybe 3 valve problems instead of 1 valve problem, how are we going to address that? How do we optimize what can they get through? What can be done in one setting? Those are very frequent conversations now.
Mm-hmm.
So a lot of times you'll be looking at your doctor and they say, we want a couple more scans. And you think, God, I just had scans. What are they doing?
Right.
Right? So we want a couple more scans. We want to take a little bit of time. We want to put it together. We want to discuss it with our group. They're possibly trying to figure out if they have opportunities for you to avoid something like a bigger procedure.
Sure. That makes sense.
Yeah, and at the same time, until we actually do the planning to do these procedures, we don't want to promise that we can do something that can't be done
Mm-hmm.
or can't be done yet. And
Okay.
sometimes you're at a point where it's time And even
Mhm.
though next year it may be able to be done without surgery, this year you may really want to get the surgery done so that you can be here for the future
Right.
improvement.
Right. So true. So true. I don't hope this isn't a dumb question. When we feel our
There's no
heartbeat,
dumb questions.
when the heart beats, right, and it's going boom, boom, right? It's pushing out. How many beats or how long? I always thought growing up that that boom, boom was instantaneously, it went around one whole time. And I'm thinking it doesn't go that fast. That's like the speed of light. So if you tracked a blood platelet and it comes out of the heart, how long does it take before that circulates all the way through and comes back? Like how many
um,
beats?
you mean comes all the way back, like goes through the
Yeah,
whole
like how
body?
long is the full circulation all the way around? Like when we hear
So
bump, bump, bump,
probably
bump, what is
about
that?
probably about 7 to 10 beats to get through the heart and lungs.
Okay,
Um,
really?
I'm not sure how many beats it would take to get through the whole body, and it depends on the course it takes. So
Okay.
some of those platelets may go up through the brain and then right back to the heart, and some may go down through the kidneys and to the toes.
Right, that's
I
true.
mean, so
I think we just always thought that when you heard or felt your heartbeat, that one beat to the next, it traveled through the whole body, which I realized as I got old, that's probably very impossible. So that's amazing to take 7 to 8 beats probably to just to get through the lungs and the heart. That's a long time. That's just kind of feel like it's just sitting there and just kind of moving its way through a track. Is that what it's doing?
it's circulating, and again, a platelet is a clotting uh, a cell. So
Mm-hmm.
it's looking for areas that are bleeding or sticky, trying to help them not bleed and to clot. So again, if you have something like a sore or you've cut yourself and you're trying to stop bleeding, that platelet may actually stick and take even longer to get back because it's got a
Oh,
job to
that's
do.
true. I didn't think about all those variables.
So
I'm just thinking
I
about
don't think I
fantastic
can.
voyage going
I
through the
think
body and then coming back around.
I'm
All
putting
right.
that down as a trick question.
Okay. I'll see if I can find the answer. We often hear terms like widowmaker. What's a widowmaker?
So you're talking about coronary disease,
Okay.
right? You're not talking about aortic disease at all. You're talking about different anatomies of coronary disease and a lesion that's in a place that is close enough to the tree trunk of the vessels that it could actually stop the circulation to the heart itself. So the
Oh.
coronaries, um, we'll use this one. The
Mm-hmm.
coronaries are vessels that come off of the aorta. They're arteries, so they have the red blood, and they are going to supply that red blood to feed the heart itself. The heart
Okay.
itself is the hardest working muscle. It works no matter what's happening. It
Mm-hmm.
works when you're sleeping, it's working when you're thinking, it's working when you're exercising. It's always working, even if you're not thinking about it. And the heart actually extracts the most blood from it compared to any muscle. So one of the pearls is that the return of the blood from the heart is the darkest blood in the body. It's the blackest blood in the body.
Okay.
And it comes through a vein called the coronary sinus as it returns back to the heart to go through the lungs and pick up oxygen again.
Mm-hmm.
Because the heart extracts everything it can from oxygen and nutrients.
So interesting.
So
I'm
a
having so
widow
much fun.
So
Yes,
widowmaker
widowmaker.
would be
Yeah.
a blockage. Traditionally, it's meant to say a blockage not in the left main, which is the true widowmaker, but
Mm-hmm.
the left main or left anterior descending artery that supplies the front wall of the heart and would be
Okay.
one of the biggest territories for a heart attack.
Okay. So a lot of times people have calcium scores, right? In some scans. What exactly is that checking and why does that mean anything?
So a calcium score is a marker of how much calcification of the vessels an individual has had in their lifetime. And
Okay.
it's really well validated between the ages of, say, 40 and 70 as a marker and predictor of coronary risk. Obviously, you'd like to be a zero.
Mm-hmm.
Calcification happens because of injury to the vessels from lipids, from blood pressure, diabetes. smoking, environmental exposures, diet, weight, all of these risk factors for coronary disease. And any one or combination of those can injure the vessels, and then as part of the healing, there's calcification. So calcium doesn't tell you that you have a 10% or 99% blockage. It just tells you that there's been some injury to the vessels, so it's a good predictive marker.
Okay. What can you do
so
if you score
It's
something?
done on a non-contrast CAT scan.
Okay.
The scale, you'd like to be a 0, right? Not everybody's a 0.
Right.
More than 400 really correlates with a significant blockage in one vessel, more than 1,000 in all the vessels. So again, it's one marker. It's not something you would do yearly. It's not always covered by insurance. The scoring is being added to many of the scans to try to not miss coronary disease as something that people can address and can prevent problems if they know they're at a higher risk. So, for example, if you get your aortic screen and your calcium score is then reported as 500, right? You know that you also need to address coronary disease, and you may need more stress testing, more attention to symptoms, more attention to your lipids, your blood pressure, your diabetes control, screening for diabetes, family screening. So it's a different disease process that certainly could be the reason someone has aortic disease, atherosclerotic disease. In this group is not always the reason why people are actually here, but may have concomitant disease. And 1 in 3 Americans dies of heart attack, and 1 in 2 Americans dies of heart attack or stroke or vascular disease.
Right. That's huge. Okay. I have asked you all of my first set of questions because they keep popping into my head as we talk. The longer we talk, I want to check in and see who's with us. I know I'm really testing you tonight. Boom, boom, boom. Who's with us, and if we've got questions from anybody that's out there.
All right, let's say hi to Valda and John Brenny,
Hey.
Christina Kohler, John Toivonen, Tom Nowetner, and Molly Thomas.
Hi. Hi, everybody. Thanks for joining us.
Karen, I think you yanked your mic.
What? No, I didn't.
Just tweak it a little bit. Just turn it or something. Because does it sound a little
better?
scratchy to you, Dr. Fisher?
Is that better? Do I sound scratchy?
That's better, yes. Thank you.
Yeah.
Okay. Well, there you go. Technical wonderland. Did anybody have any comments or questions?
Just the highs so far.
Hi, everybody. All right, then we are going to talk a little bit about valve disease. Let's move on to valve disease from the heart, since we just had Valve Disease Awareness Day. And if you want to go back to your picture, because I think there's some great diagrams there about stenosis and regurgitation. And if we can talk a little bit about that. Yeah. There it is.
So I'm not sure what you want to talk about.
So
Aortic
what
valve
is,
disease?
yeah, so when we hear regurgitation, what does that really mean?
So regurgitation would be a leaky valve. And that means that blood can go, so for example, for this mitral valve, I'm sorry, I'm looking backwards. This is a tricuspid valve. So if blood comes from the body into the right atrium or right ventricle, it should then go out to the lungs. But the heart squeezes if the valve is weak or has a gap or has a hole or isn't formed right. Some of the blood may go backwards where it came from. Does that make sense? So a leaky valve means that it's not separating the blood from going backwards.
It's kind of like regurgitation from your stomach. It just comes back up and it's not supposed to. It's what it sounds like.
I prefer this type.
I know that you do. So do you get the same kind of symptoms? Can you have fatigue and shortness of breath? I just don't know if it's the same as what people that have aortic regurgitation, would they experience the same things?
So yes and no. I mean, again, anything that makes the pump inefficient can give you lower output symptoms.
Okay.
But there are nuances of the different valves and the right-sided versus the left-sided valves. So the left-sided valves would leak backwards into the lungs. So often will flood the lungs, where the right-sided valves leak backwards into the liver and can congest or hurt the liver. So some differences in the presentations, what you would find on the physical exam, the way they sound, all of them can affect the rhythms.
Mm-hmm.
So heart valves can stretch the heart. The volume lesions or leakiness will make the heart get bigger and baggier, where tight lesions like pressure lesions can make the heart thicker and stiffer. So it is different. And what you get as far as side effects of that is a little bit different.
Okay. And then stenosis would be narrowing, or is that thickening? Is it just narrowing and some calcification on the valve?
All of that.
Oh,
So you
okay.
could be born with too small of a valve. You could have too small of a valve in for your body size.
Okay.
That's called patient prosthesis mismatch. You could have, you could get older and have wear and tear of your valve, and it could get narrow. You could have rheumatic fever, rheumatic heart disease, and get thickening and narrowing of the valve from scarring. You could get a muscle problem and stretch open your valve and get a leaky valve. So there are a lot of things that can happen to the valve, or you could get an infection from an infected tooth that you haven't taken care of into the bloodstream that eats a hole through the valve.
Wow.
And then the valve is leaky.
Okay.
Right? So
interesting.
A lot of different variations of what could actually happen to the valve. And all four of the valves have their own pathophysiologies.
But one of the things that
really focuses on the aortic
it totally
valve.
does. Yeah.
Yeah, with this valve is a valve that you might see in an older person with calcium deposits on the valve that can come related to a high lipoprotein little a and family likelihood. It can come from prior infections of the valve and valvulitis. It can come from wear and tear on the valve. It can come from calcium problems like parathyroid hormone problems. So there's a lot of things that can actually affect this valve. But that can come that way. I think if we look, this is a healthy aortic valve, one that has 3 leaflets, equally sized, opens fully. This is one that is a diseased valve that has these nodular calcifications of the valve that I wish you could feel, but you can kind of
I know. I want to.
here.
I will when I see you next time.
And then this is just a picture of the nodular calcifications. And this valve, when it's fully open, is only open this much instead of this much.
Right.
And you can actually measure in planimeter like the size. So this may be 0.6 or 0.7 centimeters, where this one is 3 centimeters.
Wow. Okay.
So it's a big difference in fixed narrowing. So if you think of a pipe where you need flow to go, and the pipe goes from 3 centimeters down to 0.5, you can't do the same thing. You can't make up for not being able to get enough through it. Your water pressure's low, right? And when it becomes a trickle, you have to do something about it or you can't.
Right. Now,
so
we talked.
That's a good analogy.
We talked one time because I know people on their echoes can get results that say mild regurgitation, for example, or moderate or mild to moderate or moderate to severe. But then all of a sudden, like let's say if your blood pressure was not well controlled, but you get it controlled, all of a sudden the echo can say it got better. And I think people sometimes are confused by that because we know aneurysms don't shrink. So what's really happening with the valve that things can actually, do they actually potentially get better?
Yeah, and they can get worse again if all of a sudden you raise your blood pressure really high. So the valve is a dynamic moving structure, right? That's opening and closing, and a diseased valve is going to be weaker, right? And it's going to have some fixed amount of opening and closing. So if your activity level requires a huge output, your valve may be under tremendous stress and may have more trouble meeting that requirement. If you think about where the aortic valve is, it is between the ventricle that would be, say, here, let's put a ventricle. I'm going to add this person's ventricle back on. This is their 3-leaflet valve. And here is their ventricle. So you have the left ventricle, got to make it fit. So you have the left ventricle pumping out to the aorta here, right? And the valve is right here. So the job of this valve is that when this pumps, it keeps blood above it and not below it. Well, this vessel has a pressure. So if you think about the diastolic or bottom number blood pressure, that is the difference when the heart is fully squeezing. That's the difference in the pressure between what's above the valve and what's below the valve. If there's no valve, you're not going to have any difference. If the valve is severely leaky, that number is going to be low, so you'll get a low bottom number on the blood pressure. If you make the blood pressure really high, so you take someone who has a bottom number of their blood pressure of like 80, and you give them Chinese food, and then you scare them, right? You take them to a horror movie, and they're terrified, and their blood pressure skyrockets. It puts a ton of pressure back against the weak valve, and you can actually see the flow increase. Right? So you can push a diseased valve open. Okay. And you can also use medicines like the medicines that have been shown to help reduce leaking in a leaky aortic valve would be the calcium channel blocker dihydropyridine, so nifedipine, amlodipine, or the ACE inhibitors, ARBs or ARNIs. So lisinopril, enalapril, that type of drug, valsartan, losartan, irbesartan, that type of drug, and Entresto. So those drugs have been shown to actually lessen the leak that you have, which can make the valve last much longer. So it may not make it last forever, but you could get years longer out of the valve that's there. That's a weaker leaky valve. And when you watch it on a day-to-day basis, it's not leaking so much. And when it's not leaking so much regularly, it's not hurting the ventricle below it. So when it leaks, it's volume, and it will make this ventricle get baggy, get more dynamic, and then it'll start failing. So it'll get back to normal, and then it'll start dropping its function. And it'll get bigger and bigger and bigger. And there are clear guidelines about when it's too big, that it won't go back to normal if you don't fix the valve. So having the regular surveillance of a leaky valve is the most important thing you can do to make sure you don't miss your window to fix it.
Which is what I'm doing with you.
Yes.
You know, I share all my stuff, but this now is making so much sense to me. It's actually comforting me. Knowledge is power to me and my psyche. I'm sorry, you know that. All right. So before we move on to the third topic of tonight, I want to just double check and see if we've got any chatter or questions. Give everybody a chance. Anything, Josh?
I have to unmute. Okay, so there is a question that I think that John Toivonen is putting inside of the comment section and not in the chat. I think that's what, because he says I just put it someplace.
Okay.
But I'm not seeing his question come in. However, we do have an anonymous question.
Oh, okay. What's that?
So this user writes in, my wife had aortic and mitral valve replacement in 2017, porcine valves. 2019, ascending aorta aneurysm surgery just above the root to her arch. 2020, aortic valve failed, TAVR repair. 2022, mitral valve failure, transcatheter repair valve, in valve. CT shows 5.9 aneurysm in the distal arch. 2023 FET and valves replaced mechanical valves diagnosed giant cell aortitis. 2023 450 millimeter TVAR extension from FET to celiac artery. Can large vessel vasculitis cause the valve failures? Blood pressure has been difficult to control. Isolated systolic hypertension. Her diastolic is under 60. She's on Entresto and bisoprolol. I don't know. Is there anything that can raise diastolic without raising systolic? Thanks. Surgeons leave BP to cardiologist, and ours is scratching his head.
Yeah, so again, not to give sort of individual recommendations, but first of all, vasculitis is a very serious condition that is an autoimmune or inflammatory condition that can weaken the vessels. And it weakens them through inflammation. And vasculitis can affect small, medium, or large size vessels. Different antibodies have a different propensity for parts of the tissue and will weaken the tissue in different ways, so affect different areas. It's very important in those conditions to actually have a rheumatologist involved, which is not what's needed for everybody in this group. But a rheumatologist would be looking closely at the immune suppressing medications and how to treat the vasculitis so you stop having injury. So that's really the underlying very important thing. Vasculitis can cause high blood pressure in other ways. For example, if it's one like giant cell that can affect the kidney arteries, you could be getting high blood pressure because of the way the inflammation affects other arteries. So it's important to screen all of the arteries, especially because, as you've said it for your wife, there's progressive disease and it's affecting other parts of the aorta. So if the blood pressure is going up, you're going to actually want to, address that even more. As far as, so you're going to have cardiology involved, looking at the valve functions. You're going to have rheumatology involved, looking at suppressing the giant cell arteritis. And it's really important that that was diagnosed so that you can actually stop the progression, because it doesn't sound like there's an underlying genetic or connective tissue problem like Marfan's disease or Ehlers-Danlos. It sounds like there's an autoimmune problem. So again, very important, very different question. As far as blood pressure medicines that affect just one number or the other, there are some that affect one more than another. For example, the diuretics and lower salt diet are more helpful in bringing down the bottom number, but do bring down both numbers. Somebody that has a very narrow pulse pressure, meaning the top and bottom numbers are too close together, often that's a symptom of low volume like anemia or dehydration, low output. So those are things that you would want to address. Actually, more water and less salt can do a big job for that. So certain medications definitely play a role. Blood pressure medicines have to be closely monitored because they can affect your potassium, they can affect your kidney function in good and bad ways. They also have certain ones, for example, the nifedipine or losartan for the aortic insufficiency that do prolong the life of a valve that's insufficient. So you're going to try to get them on. We always try to have secondary benefits of blood pressure medicines and not just a primary benefit with nothing else, because we've learned to try to get more out of our meds. The average person with high blood pressure is on 3 or 4 medicines. But again, if your wife never had high blood pressure before and all of a sudden does, you do want to consider the flow to the kidneys, which is the renal arteries, and making sure that those are not affected by the vasculitis.
Interesting. It's very, very interesting stuff. Thank you.
I just want to add that was a magnificent answer. I'm stunned.
Oh, thank you.
I really am.
Hopefully it's helpful.
It was such a giant question, and the delivery was amazing. Molly says, can I come with you?
Well, then I'm coming back.
You always come back.
Molly says, can I come with you to your next cardio appointment, Karen? I love your Dr. Fisher. She explains everything so nicely.
Of course you can. Of course you can. We'll do a field trip.
And I think I know why this was getting censored, this question in the chat. So this is an interesting one.
Okay.
Is there any studies out there about Agent Orange exposure that are causing heart issues in children born from Vietnam veteran father?
Oh, interesting.
So honestly, I don't know the answer to that. There are studies looking at offspring of Agent Orange. Many of those studies are being done through the VA medical centers. There have been a lot of, there's been a lot of injury and trauma from Agent Orange. It's not clear kind of who's had what doses or what exposures for how long. And, really it's all from people that have been exposed that this data is coming. So I don't personally know the answer to that question. I wish I did. I don't know that that's a bigger issue in this group, this support group. Actually, you could even pull some of the members off label and, off of to the side and see if people have had exposure or are offspring of Vietnam vets. So, and if there's a higher number of people in the group that are in that position, then maybe it would make a case to look at that question. I am not aware of a higher incidence of aortic disease in offspring of Vietnam vets.
I'm going to go ahead and applaud that answer as well.
Thanks. This is a hard session here. I was unprepared.
So, and John, he wants to point out, he says, my dad had it dumped on him for 6 months.
Oof.
And so even still, right? Yeah. So even as you say, we're not sure about the variables involved, then you have this giant exposure, long-term, what exposure dose, the whole nine, right? So that's
well,
a big labyrinth.
First of all, thank you to your father for everything that he did. In the Vietnam vet era, there was a lot also of smoking, alcohol, harsh conditions, PTSD and trauma, high blood pressure. So there are a lot of people that suffer with things like vascular disease, coronary disease, lung disease, and emphysema, COPD, skin issues. So there are a lot of complicated multiple system problems, health problems that are present. And sometimes you can actually go and talk to one veteran and see all of the adult problems that happen to many people. And it can be very hard to decipher like what is related to what, because the stress levels were so high too. So thank you to your father. And I'm sure that there is a lot in the background there. But aortic disease hasn't been well described in that. Certainly it may be an under description, but I don't think we know the answer to that.
Thank you.
Yes, thank you. And John says it was a terrific answer as well.
He says, knocking it out of the park.
He says his dad, his father's death was linked to it. His dad never smoked or drank in his life, which is strange.
Yeah, and again, it's a toxic agent for sure.
Right. Yeah.
Molly asks, how do you test for aortitis?
So aortitis, you're going to test for through imaging. Sometimes you see beating of the vessels on the imaging and also blood work. So you get inflammatory markers that are high in the blood work. And then if there is a piece removed and you're looking at it under the microscope, it has pathological findings where you would see inflammation. Certain sequences of MRI imaging can look for inflammatory responses, aortitis, pericarditis. So there are some nuclear and imaging screens that can be done. Generally, sedimentation rate, C-reactive protein would be very high. Lupus can have aortitis where your lupus markers, your ANA might be very high. So any vasculitis or inflammation of the vessels can do that. The other thing you wouldn't want to miss with the aortitis is actually syphilis. And syphilis, as a late-term issue, can cause cystic medial necrosis or weakening of that part of the ascending aorta and an ascending aortic aneurysm. So in people who have aneurysm, you'll often be asked to test for syphilis through the blood, just because it can be a latent finding, meaning they didn't have any other symptoms, and all of a sudden they have a large aortic aneurysm.
Shazam.
Thanks, Molly. Okay.
Okay.
Anything else?
And that catches us up to our
Okay.
question section.
Perfect.
Oh, wait. Follow-up question from John Tavoynin.
Okay.
Are there any devices out there that are for right side heart failure, like LVAD for the left side?
So that is a really tough question. There are, but not in the same league as the left side. So the right side artificial support devices, and just to bring the group into this, because that's a tough question, the question is really asking about supporting a ventricle that can't support itself. So if you come back to our picture here, the right side is going to be, again, the thinner walled side. And if this side is not working for one of many reasons, you were born that way, or you had a heart attack affecting the right side, or during your aortic dissection repair, the right side didn't get enough blood and had acid injury and isn't working to get blood into the lungs, what can you do about it? So there is a catheter that can go in through the axillary artery in the arm, or up through the artery through the veins to get into here, or through the veins in the leg, come into this ventricle, out through the pulmonary artery, which is next to here, into the lungs, and pump the blood from the veins into the lungs. That is not one that you can keep forever. It is not the most mobile. And the right ventricular assist devices, which are pumps that you can actually pump blood, take it from the vein to the pulmonary artery, those are kind of a long tube heavy pump that will actually pump the blood that you need 5 or 6 liters per minute. If you think about how much that is, it's a lot, right? That's what the heart does when it's working fully. Less than 2 liters per minute, most people are shocky. So it's important that we get enough flow. Those pumps can be done at the bedside, but are very hard to move with. Don't do well going home. The left ventricular assist devices, through this nice thick muscle, are now to the point where you can basically put them in through the apex. They will take blood from the heart and put it out into the aorta. So it pumps for you. It's an external pump. And people have those. They're tunneled under the skin. They come out through a wire will come out through the body to actually plug in and recharge the battery. And you have extra batteries. So you are electricity dependent with an extra 12-hour battery, and you can actually go home with those. We don't have one that, like a totally artificial heart, that is working well enough for people to generally go home. We don't have a BiVAD where you do both ventricles. That's good enough for people to generally go home. And the right ventricle supports you're generally in the hospital until you either get better or get a transplant.
Okay. Wild stuff.
And a more temporary form of that is called ECMO, which you've probably heard more about through the COVID pandemic, because there are ways to basically keep a bypass machine circulating blood through an oxygenator if the lungs aren't working, or just circulating it through a pump if you just need to augment the flow. So there are a couple of variations of ECMO, or extracorporeal mechanical support, to actually help somebody who's in shock.
Okay, that's actually a great segue to a question that I forgot to address here. Christina asks, how does bypass work during surgery? when you go lung heart bypass machine?
So again, a complicated question, and the bypass machines really didn't even exist until the 60s, 1960s, which is when heart surgery became available on a limited basis for mainly for heart bypass. But the bypass machines are there to oxygenate the body and protect the heart during the surgery. So basically, there's a cannula that will go in to pick up the blood where it comes into the veins. And then there's a cannula to go out to the body. And if people have variations in their veins, like an extra vein, sometimes you need a third cannula. So you basically take the blood entering the heart into the machine that will oxygenate the blood, right? And put it back into the vessel going out to the body. So you're bypassing the heart and you're oxygenating the blood so that the body lives while you're working on the heart. The heart is actually stopped, and they use something called cardioplegia, which has some preservation for the heart while it's stopped, and they actually do pack it in ice to try to keep the heart muscle from getting hurt while it's not working.
Amazing.
And then every so often they'll pump a little bit of blood through it to just keep it going. So it's amazing technology, and it's why we've been able to do this. And then if you think about the fact that we've gotten to the point where they can do preemies and infants, and generally get away with it, and you're using these tiny cannulas, we try to get people to say 5-6 pounds before we try to get through it, because the morbidity is so much higher earlier. But it's amazing advances in surgery and pediatric heart surgery, which is why we have survivors. It's why I have the career I have of taking care of people that have been, have lived through pediatric heart disease. It's all on the back of pediatric heart surgery and the bypass machine.
Amazing.
It is amazing.
Yeah, and honestly, if I could recommend a movie, and full disclosure, I'm at Hopkins. I love living upon the legacy of Hopkins, the Blaylock Thompson Taussig legacy. There is a documentary called Something the Lord Made, and it's the story of Blaylock Thompson Taussig. It goes through everything from the development of the bypass machine to the Blue Baby story and the first shunts that were made, just trying to help the lung get better blood flow when the lung was starved of blood. And it goes through that story, including the biases, including the bigotry of the time, including the developments. It's an amazing story that is a true documentary that I think is just a way to really appreciate this world.
I can't wait. I wrote down Something the Lord Made.
Yeah.
I'm going to check it out.
All right, and let's say hi to Mike Dorsey.
Hey, Mike.
He's got a question here. Let me make sure that I'm not muted again. Okay. Mike says, I had my ascending dissection in 2021. I had a biobental to fix it. I had coarctation corrected when I was 13. My calcium score is 0 and my EF is 60. My BP is 132/75. What else do I need to check?
So first of all, if you've had a coarctation, what that means is that there's a narrowing. You were born with a narrowing in the descending aorta. And the issue with that is two things, and yours is repaired, and we'll get into that in a second. And 50% of people that have that have a bicuspid aortic valve. So the assumption from my part may be wrong, but is that you probably had 2 leaflets instead of 3 of the aortic valve. The connective tissue was weaker. It was under pressure because of the very high pressure trying to get blood across the narrow descending aorta. And that contributed to the aneurysm that tore. So very important background, very different than, say, again, somebody with Marfan's or somebody with aortitis that we've talked about a little bit. The repair of the descending aorta often involves the left subclavian artery that gives blood flow to the left arm. So very frequently, probably 60–70% of the time, in that repair, the left arm blood pressure is going to be a lower number than the right arm. So your blood pressure management should all be done through the right arm. Your goal should be really the 120s over 80 or less average, one higher number. We don't like to treat every number. We like to really look at the averages in the range and try to give you a normal experience, but not hurt the heart. It's wonderful that the calcium score is 0. There can be turbulence and re-narrowing of the descending aorta, or some people have a graft that's small for an adult when they had the repair as a child. So, every few years, really having aortic imaging of the repair site, making sure that you have enough room for flow, that you don't have a gradient developing, and that you're not getting very high blood pressure. High blood pressure develops and stays in that condition because if the aorta is narrow, you need a lot of pressure to get past the narrowing. And also, before the repair, the kidney vessels had less flow there after the narrowing, and the kidneys, the vessels can underdevelop, and then the kidneys actually help set the level of the blood pressure. So most people who have their coarctation done at a time after childhood or young childhood often are on 3 to 4 blood pressure medicines to get control. So very important to stay in care. Often that condition, is highly accepted, and it's a good idea to be in adult congenital heart care. There's an adult congenital travel directory where you can see providers in every state that are vetted by the Adult Congenital Heart Association. So that's a good resource in finding care if you're moving around or you're living in different places. So I don't know, that I would think I was a little circuitous if that helped, or if you have other questions.
I am still hypnotized by the answering here.
Too much?
It's wonderful. I love
it.
It's good. It's good. It's all good stuff.
Okay, and that catches us up with chat.
Perfect. Great. We're going to bypass women and men difference in heart issues just because we're pressed on time. And I really want us to talk about CPR, because I believe there's a lot of people in this community that have a misconception that if you have an aneurysm, if you've had a dissection, that you should not receive any CPR. So I'd like you to address that, and then I'd like you to talk about the importance of CPR and what that actually means.
Yeah, so CPR, first of all, hopefully you never need it or you never need to do it. But if you have an emergency, something like a widowmaker, a heart attack, or issue or choking episode, learning CPR, number one, empowers the person that has learned it to know that they've done the best they can do around an emergency. So it's very important for yourself, your family members, your children to actually learn CPR. And then as they do that, they are a provider for your family, for you, and for the community, but they also have for themselves the knowledge that they can do everything that can be done. So out of hospital cardiac arrest, there is about a 5% survival rate. In the airports, it's actually currently about 15 to 17%. And that is because the airport security is trained, and BWI Airport here is actually one that has these numbers. And it's very exciting that the numbers are better. And the reason they're better is there's a lot of people around. There is an AED on site. These security people, the TSA people, the stewardesses, they're getting trained. And there is a cart ready to go with a buggy to get there so that there's quick access to care. And the care is delivered quicker. So having the care more immediate is actually life-saving. Very important to know that. It's so that, we try to encourage the AEDs to be available in all of the bigger buildings, on the sports fields, in the malls, in the airports, places that you may spend more time or congregate more. having first responders around you in your home is very smart. Now, if someone has a ruptured aorta, it's true that CPR may or may not help, right? So if it's blood loss, it's not going to help. It's also not going to hurt.
Right.
Okay, so if it's a coronary event, which somebody with aortic disease could be at risk for as well, the same vascular issues that affect the aorta could affect the coronaries, or the same vasculitis, or the same atherosclerotic disease. And if it's coronary disease causing it, sometimes not getting enough blood flow through the coronary will trigger a rhythm issue, which absolutely can respond to CPR and then eventually a shock when you can get the AED there. So it could be something that's recoverable, or the aortic disease could have caused a small scar in the heart. If there was a dissection in time where the blood pressure was really low, you could get an arrhythmia from that area of scar, and that could prompt a rhythm issue that could be very shockable and responsive to shock. So if you can, physically and mentally, learn CPR. It's a gift to you and to your community, and especially to your family, and use it. And during the training for CPR, you'll learn to recognize issues with airways, breathing, and circulation. You'll be much more comfortable in addressing those issues. And again, if everybody around you has learned, you have the best opportunity to recognize what's going on and to make a difference.
So
it's
if
also,
you have,
again, important to know somebody's wishes.
True. That's it. That is important. And that is something that you can put on your medical ID, or, you know, a dog tag if you're wearing that. So if you have an aneurysm, and for whatever reason, you're in a position where you could use CPR, doing CPR, is there a risk that you're going to rupture that aneurysm or cause a dissection, or?
So I think the bigger risk is that it did rupture.
Oh, okay.
Right? Because again, CPR, if you need CPR, you're pulseless.
Right. Okay.
Right? So you're in a position of extreme, you know, it's an extreme position.
Mm-hmm.
And the question is saving life. So your best likelihood of saving life would be to give the CPR.
Is to do it. That's true. I mean, and if you're someone choking and you know someone has an abdominal aneurysm, which we were just discussing before we went on, your best chance of helping to save that person is to just do, you know, a form of CPR to get that out. We used to call it the Heimlich. I don't know that it's still called that anymore. Okay. And you just do that, because then you have an opportunity to unblock the airway. And then, you know, I would think that you're probably not going to damage the aorta, but like, who's going to think twice about it? You just want to get the person to breathe. And if you don't do it, they're not going to breathe.
The right thing in an emergency: airway, breathing, circulation.
Yeah.
So you look at those three things in that order, and you try to restore them. And you always call for help, right? Because you shouldn't be on your own. But if you're the only one there and the first one there, you also, when you call for help, they will help talk you through it. And they'll help you make good decisions. They'll either talk you through it from their algorithms, or they will put someone on who can help you while EMS comes. So you're not alone. And again, in a time where a loved one is having an emergency, you want to be able to think. And if you can't think, the person on the phone can. Right? They're not emotionally involved. They're involved in a way where they can think. They have an algorithm. They have resources. They can research. They can have a physician or a trauma center on the phone. So remember, you do have those resources, and that's the right time to use them. But don't make a decision not to do something that you might regret later because you're scared. You know, call and ask for help, get the support. And if you get the training ahead of time, you really feel much better. And Heart Month, really, CPR training, it's the perfect thing to do for Heart Month. You know, go get trained, be a provider. We are trying to get legal pathways so that there's funding and availability or resources for every high school person to be trained before they graduate. So then you can do that. You have entire population of first responders.
Right. I just actually met a mother in Harford County I think that she helped pass Bailey's Law. I don't know if you're familiar with that.
Yeah, absolutely. I
Yes.
know
So
her.
I met yes, I met her,
Bailey, yep.
and her son, was a track star, and I guess had finished. He was in high school and just collapsed and had a cardiac event, and it just took so long before somebody, another child was able to run and finally get somebody. And then that person moseyed their way through the school, eventually found an AED, came back, I think without this great sense of urgency, because I don't think they felt confident in what they were doing. But needless to say, her son did not survive. And now, because of her activism, I believe all of the high schools, right, in Maryland now have AEDs. And people are being trained. So this goes beyond just your security guy or janitor. I mean, everybody in the school is being trained. And and I had training at my job before the dissection. It was like that week I came home, my husband had a horrible stomach flu. And I remember he stood up, he was on his way to the bathroom, and he said, I think I'm going to pass out. And there was no time for me to even get out of bed. And as he passed out, he cracked his head on the dresser and was just laying there. And the first thing I did is I turned to say, call 911, because it was so drilled in my head to ask for help. But then I realized, all right, I'm the only one. And immediately you check, is he breathing? Is there a pulse? And of course, he came back right away. And, and I stayed up to make sure he kept staying awake all night long. But that was scary. And I had just passed with flying colors, but your brain does snap into, what do I need to check and assess real quick?
One of the amazing things is that you are the person with aortic disease. And instead of saying, I want everyone around me trained, you said, thank God I'm trained, because my husband, who's helped me all this time, had an emergency, and at least I know how to help her. I know what to look for, and I know what to do. And I have my wits about me, and I'm going to call 911, and I'm also going to have them help me get through this. So it's really wonderful, and it says everything that, you're thankful you have that training. Yes, so that absolutely. Training is widely available. American Heart Association often does a lot of the training, or sets up a lot of the training and certifications. A lot of them are done through the fire departments with American Heart Support and volunteer support. So those are wonderful opportunities to help yourself, your family, and also your confidence. And it does not take very long.
No. And it's actually, it's just like anything else. After that happened, there was another episode at the job where someone passed. Things start happening, and it's because you're trained and you're knowledgeable. Even in first aid, I took them both together, and all of a sudden, things are just, they weren't happening before, but then they were happening. But I felt a lot more confident to address the situation. And my husband and I were just talking yesterday about it, and he wants to become certified. So that kind of makes me feel a little good too, that somebody else is in the house will know what to do if there's an emergency with me. So yeah, thanks for bringing that up as a final ending talking point. We're going to do one last check-in for questions real quick. Anybody? Josh?
Yep, last little bit of feedback here. Let's see. Velda says the doctor should get an award for amazing answers. John Tavoynet says, yes, Velda, she's amazing. Molly says, get a conference room for the next cardio appointment, Karen. I think we're going to have a lot of Dr. Fisher fans. And then Molly says she's CPR and AED qualified.
Oh, good.
Yeah, she does flight work. And then Mike Dorsey says he did have a bicuspid valve.
Oh, see, ding, ding, 50-50 shot. And you were right. Look at that.
Well, I think considering he had an aneurysm, it was probably like a 99-1 shot.
Right. Okay. Well, then you knew.
Yes. Thoroughly entertaining and thoughtful answers. Thank you so much, Dr. Fisher.
Yeah. This was wonderful. And everybody, again, do me a favor, click that, subscribe button, click the bell so you're notified when these types of events happen, and you won't have to try to remember. It'll pop up on your screen. And share this. There's a lot of really valuable information. Share it, get it out. It's Heart Month. It should go out every month. This is very, very important stuff. Thank you so much for doing this with us tonight. I appreciate it.
Very welcome.
It's always wonderful. I'm sure I'm seeing you soon for something, so we'll catch up when I see you then.
Happy Heart Month, everybody.
Yes, happy Heart Month, everyone, and thanks again so much. We'll see you soon.